Good morning, everybody. It is a great pleasure to be talking to you all in the Society of Chest Imaging and Interventions annual conference. It is really nice to have you here, and I would like to thank the organizers for putting together such a great show and looking forward to many more lectures in the coming few days. Today, I'm going to be talking to you about the different protocols that you may need to follow in emergency department when it comes to imaging patients with chest pathologies. This is a interesting topic and very useful topic, but unfortunately it is heterogeneous topic in the sense that one rule does not apply for everybody, and there are multiple parameters that you will have to utilize and look after when you are scanning these patients. My objectives today are to let you know how to get the best images, and at the same time I'm going to be making you aware of different parameters that you may have to change or that you need to be aware of that will influence your image quality. Any emergency department, be it radiology emergency room or be it accident and emergency room in the hospital, is a battleground for chaos. There is so much of confusion happening around there, so many lines of communication between different teams that it can be very overwhelming. It is very important as an imager that you have a very clear picture in your mind and you do the appropriate action in these patients. I like to train my fellows with these following rules. The first and foremost rule when it comes to imaging, whether be it emergency situation or elsewhere, is to know the clinical question. You need to be aware of what the clinical question is before you do the imaging, before you do the reporting, and at the end of the reporting, you should be sure that you have answered the clinical question. The next rule that comes up is looking at the contraindications for a CT scanner or giving contrast in patients. It is important that we are aware of what contraindications are there. In some cases, these contraindications may be overseen because of the urgent need of diagnosis. Then you have to look at the risk-benefit analysis in these patients in terms of doing the procedure. The next rule comes is venous access. It is very important to try and get the venous access as close to the heart as possible. So rather than in the periphery, if you can get it in the antecubital fossa, then you may get much better quality images because the contrast delivery into the heart is much quicker and much faster and more predictable. Another rule is to look at the heart rate of the patient. Patients who have very high heart rate invariably give you very bad image quality. It is often due to contrast dilution because with every heartbeat there is little blood pumping out, so the heart never accumulates the contrast that we have injected and it just gives us a washed off images. So heart rate is an important factor which will help you in deciding which parameters to change in these patients. So, as a summary, remember to know what the clinical question is and ensure that you are imaging to answer that question. Secondly, risk versus benefit ratio when it comes to doing contrast or CT examination in patients where it may be contraindicated. Also, put the venflon closer to the heart or the venous axis closer to the heart. But the central lines are not necessarily good because you cannot inject a high contrast rate through central lines. They often burst. So although the central lines are within the heart itself, they are not great for giving high infusion rate of contrast. Also, any heart rate, if it is slower, is better. Whatever imaging you're trying to do, a slower heart rate is better. One of the most important parameters which makes a huge difference in the quality of the scan is the scanner itself. Okay, and within the scanner there are two parameters that you need to know. One is the distance it covers with every rotation. By the terminology that we all use is the number of slices. So the standard terminology we use is 64 slices. I like to use, rather than 64 slices, I would rather use 64 rows of detector. You need to know how many rows of detector is available in your scanner. And broadly classifying, you can put scanners as those who have less than 64 rows of detectors and those who have more than 64 rows of detector, because the protocols will change in these scanners and the way we do examinations will also change. The second important feature is to look at the temporal resolution. Temporal resolution is determined by the speed with which a scanner rotates. So if you have a scanner which rotates very fast, then the image quality will certainly be much better, and a high heart rate may not be that big a problem for you. The next important parameter which comes is contrast. We can have different densities of contrast, the 270 or isoosmolar contrast, 300 or 350 density of contrast. Low density, if you use 270, you have to reduce the kV. By reducing the kV, the contrast versus noise resolution improves significantly at a low density of contrast. The other advantage of using low density is you may be able to give more volume of contrast if you're using low density of contrast, because at the end of the day it's the iodine dose that actually relates to any contrast induced nephropathy. So lower density contrast, lower the kV, lower density contrast, you may be able to give more amount of volume also. The next thing comes is the amount of contrast that you give. So as a standard, it is 1 ml per kilo of patient's body weight, but it can go up to 1.5 ml or even 2 ml depending on the condition, and we will talk about this in more detail. Power injector is very, very important. You have to use it. The rate of injection will vary from 3 to 5 ml per second depending on your indication. If you have a faster scanner, your injection rate should be higher. If you have a slower scanner, use a slower injection rate. There is no logic in injecting all the contrast in while the scanner is not getting you the scans in the same quick time. So also, if you're doing a simple chest, 3 ml per second is pretty good. If you're doing an angiogram study, you have to use a higher rate of injection. It is very important to time the contrast examination appropriately. The trigger time is the time where you start the actual examination is very, very important. Traditionally, we used to have test bolus technique where we would give a little bit of test bolus, look at the timing when it reaches the most appropriate part, and then we would use that timing to do the scan. This has now been replaced by what is called as a bolus tracking method, whereby we are giving a contrast and we track the contrast arriving at one particular point, and we keep checking every few seconds, and then once it reaches a good level, we start the scan. So as a rundown again, lower density contrast, lower your kVp to get better image quality. You may be able to give more contrast volume in such a scan. If you have slow scanners, you need to give more contrast at a slower injection. If you've got a faster scanner, you can reduce the amount of contrast you give, but the rate has to be high in these patients. If you've got a slow scanner, you may want to trigger off early rather than triggering off late, or you want to trigger off at a lower density than at a higher density. I will show you some examples later. This is an example of bolus tracking. So you can see here, this is a plain scan and we put a bolus tracker in the main pulmonary artery. The contrast is given and the imaging is performed at a regular interval, and you can see at a point where the contrast reaches a predetermined threshold, the scanner says yes and it starts. If you have got a slower scanner, you can have this predetermined threshold lower, so the scan will start early, okay? Or the other option is for you to start the scan much earlier. So here we waited for the scan to come into the pulmonary artery, while you can also trigger off when the contrast reaches the SVC itself. So this will again save a few seconds and get you better quality images. Another thing to look at, if you see here, the threshold has been kept very high. Some technologists prefer to actually trigger off manually. They keep looking at these values here, and as it reaches the point where they think it's appropriate, they press trigger and the scan starts. Either of these techniques work. It is purely based on the experience of the individual, and one can adopt whichever works best for them. This is a very important question, and that is how much contrast to use. Is there a thumb rule that we can apply to say this much of contrast should be given as per a scanner? Well, an easy way of looking at this is to look at the amount of time the scan will last. From the scanner, you plan the scan and it says it's going to last for 10 seconds. You look at the time for monitoring or bolus tracking. Let's say it's going to take you another 10 seconds for the scan to start. So the total time of the scan is the bolus tracking time and the scan time. Let's say you get it 20 seconds. Use that time and multiply it with the injection rate, the rate at which you want to give contrast, and then you will get at a volume that you can inject. So let's say you're doing a study and you want that study to be injected at 4 ml per second. 20 ml is the total time. 20 into 4, 80 ml of injection is required. Nowadays, what we do is whatever the total volume is required, 80% of that happens to be contrast and 20% of that happens to be a saline flush. So that helps in reducing the volume of contrast without compromising the quality of images. Let's go through some particular scenarios. The most common scenario that one would come across is a plain CT scan, like a HR-CT scan for assessment of COVID or something similar in today's scenario. It's important to give breath hold instructions. It's a straightforward plain CT scan covering to the bottom of liver. That's very important, to go down to the bottom of the liver. Reconstructions with MPRs are useful. Review these before you take the patient off the table and decide whether more imaging is required, like a prone scan, or whether you need to do contrast examination in this patient. The second scenario in emergency department that you may come across is a trauma scan, and there may be suspected lung injury. In this scenario, you want to do a plain CT scan first. Do not skip this step. Second one is to do an arterial study with a contrast focused in the aorta. So trigger off in the aorta, okay? But you also want some contrast in the pulmonary artery. So in that scenario, what we do is the first 40% of the contrast is given at a higher injection rate, 4 ml per second. The next 30% of the contrast is given at a slower injection rate. So that keeps the right side of the heart also filled with contrast. And the final 30% of the contrast is again given at a higher rate. So it pushes the contrast through and you get very good images of both the pulmonary vasculature as well as the aorta. So 40 high rate, 30 medium rate, 30 high rate. So it's like a varied injection rate to attain good contrast opacification of all the vessels. The coverage can be changed as per the requirement. If there is a trauma involving the lower abdomen also, you would cover all the way down to the lower abdomen. You want to look at the aorta and to make sure that there are no major injuries. The next important scenario comes about is pulmonary angiography. And in here, I would like you to think about how to do this and what is your protocol. The first important question comes within this is, would you do a single run or a double run? What do I mean by that? I mean that you've given contrast, do you just do one run? Or would you do two runs of the same area, one after the other? We tend to do two runs, okay? And the reason for that two runs is multifactor. One reason is you get good opacification of the pulmonary artery in the first run but often you do not get to see the aorta at all. So in the second run, you tend to get good opacification of the aorta as well. So you can give a comprehensive report covering both the things. So how do we do this? You can do, depending on whether you have a slow scanner or a fast scanner, the first run could just cover from the arch of aorta to the top of the diaphragm. So the major pulmonary arteries are taken care of. This is extremely useful in patients who have a higher heart rate or when your scanners are not that fast. So you will get good pulmonary angio. The second run can then be covering the entire chest, so you will get to see other parameters. You will get to cover the entire lung, you'll get to see the aorta and pulmonary veins, etc. in there. These are two different patients who have had a two-run protocol. And if you see, this was the first run. And in the first run, what you're seeing is there is very poor opacification of the pulmonary artery. This tends to happen if patients have poor cardiac output, especially right heart failure. In this case, fortunately, we had done a second run and you can see the opacification has significantly improved. Again, this, you would never know if there is a thrombus there or not. And in the second run, you can see it is extremely well opacified. Another reason to do two runs is to look at bronchial artery collaterals or collaterals which come from the aorta into the lungs, which are a factor seen in chronic pulmonary embolism. And these are useful for us to determine acute versus chronic disease. So we follow two runs. First run, smaller area. Second run, larger area. So you get the best of both worlds in these patients. It is very important to understand the trigger point and the density at which you trigger. Remember, slower scanners trigger off in the SVC, RA or the right ventricle. Faster scanners you can trigger off in the pulmonary artery. The density of trigger is usually in slower scanners 100 HU and in faster scanners it's 150 Hounsfield units. The contrast volume, we have told you how to determine that contrast volume in these patients. Sometimes you will find whatever you do, you get poor opacification. This is very clearly seen in people who have shunts. This is a patient who had an ASD and all the contrast kept going in different directions and we never got good opacification. In patients who are postpartum or people who have hemodilution or tachycardia. In these patients, the first run is very, very important and it has to be very well planned to make sure that you do not have any artifacts in these. The last scenario that we're going to talk about deals with double rule out, whereby we are looking at an aortic pathology as well as pulmonary pathology. Patient comes in with symptoms and we are not able to ascertain which is the likely cause. Similarly, many a times you may want to even exclude coronary abnormalities. So pulmonary, aorta, coronary all put together makes it a triple rule out. It's very important that most of the CTPAs, especially if you're doing double run, they are like a double rule out, but many dissections can be overcalled or sometimes missed if we do not do ECG gating in these patients. On the other hand, for you to be very sure about getting good quality images for your triple rule out, you need a minimum 64 rows of detector and you may need to control the heart rate of these patients. So in a double rule out scenario, if you've got a good scanner, you'd start with a plain scan, a single contrast injection with a varied rate, just like what I told you before, 40, 30, 40 percentage. Single run is often sufficient when you're looking at a dissection as well as pulmonary artery, but keep a second run ready because you may find some surprises and you may want to do the second run in these patients. Trigger from ascending aorta. So you've got contrast within the aorta and the varied injection rate will make sure that there is contrast within the pulmonary artery also. So you can see contrast within the pulmonary artery, good contrast within the aorta as well in this patient. Sometimes if you do not trigger using ECG, you will get artifacts like this, which can be confusing and you will not be able to make your mind whether this is dissection or not. For these particular scenarios, you certainly need ECG gating. If you have a not so good scanner, if it's not a 64 rows of detector, then you do a plain scan, you do a single contrast injection, you may have to give larger volume at a lower rate, so the contrast is there everywhere while the scan takes much longer time to cover the entire pathology. Again, a single run, and trigger in this time, rather than going to the aorta, you may want to trigger from the left atrium. If you're triggering from pulmonary artery, you may be triggering a little earlier in there. And always go from top to bottom in this scenario so the contrast catches up by the time the scan is reaching to the lower limbs. Gating, of course, will not be possible and you may be getting some artifacts. When it comes to triple rule out, it is important that you need a 64 rows of detector. ECG gating is very important. You will need to do a plain scan where you can calculate calcium scores. Then you do a first gated scan of the whole chest. You cover from the top to the bottom of the diaphragm. Trigger from the ascending aorta. It's an ECG gated study. Again, a varied injection protocol that you will be using in them. Then you can follow this up as a second run with a non-gated study of the entire aorta. So if there is a dissection, you can see the true extent of it. If there is a trauma to the aorta, you can see the true extent of it. Also, remember when you're doing the reconstructions for coronary, just do the area of interest rather than covering the entire thing. So this is an example where you can see we've got ECG gating going along. We've got a bolus trigger which is set at 150. We are triggering off from the aorta. So this is a high-end scanner and you're triggering it off from the aorta for the first run, and then the second run will cover the entire aorta in a non-gated manner. And you will get good quality images if you're able to follow these principles. One funny thing you may come across is here. So you can see this is another patient who we tried to do a triple rule out, who's had a bypass grafts. And we were getting good quality of pulmonary opacification, and suddenly you see these lines. And you're like, oh dear, how do I analyze the pulmonary angio here? And if I look at the coronal plane, you can see the contrast within this part of the pulmonary artery is good. So go up, okay, further up, it is not so good. So in this case, this is a gated study. The scan has started from the bottom and gone upwards. And as time has gone, the contrast has washed out. This especially happens if your third bit, remember the 40-30-30 principle, if the third bit you are not injecting contrast. So the contrast has to be kept on injecting, and if you injected contrast there, you would have got good quality images in here. So in summary, I think you have to be beware of these points when you're trying to do imaging in emergency department, especially when you're looking at pulmonary angiographies with or without aorta and coronary angiographies. Postpartum patients who have hemodilution will not give you good quality studies. For these patients, try to control the heart rate. Central injection in terms of an anticubital fossa, venflon, bolus of contrast, and focused imaging with very fast rotation speed. Try to reduce the tachycardia as much as you can, which may be difficult in an emergency scenario. Irregular heart rates, if you don't have a high-end scanner, you will not get good quality coronary angiographies without controlling the heart rate. Poor venous access is a disaster to happen. If the contrast does not go at a higher rate, you will not get good quality. Breath hold cannot be emphasized on. It is important that there is good breath hold in all your patients, whatever scans you are doing. So finally, to summarize, scanner makes a big difference. If you have a good high-end scanner, most of these scans will be easier and you will not have to do too much manipulation. If you are faced with a scanner which is not that fast or does not cover a large area with one rotation, then try and understand the clinical question and answer that clinical question. You may be able to spread out your contrast injection, use the 40-30-30 principle, reduce the rate of contrast in slower scanners so the contrast injection lasts for longer, and use a saline chase, which will again help you in reducing the amount of contrast. Low density contrast can be useful in a lot of these scenarios, and you may benefit from that. When it comes to pulmonary angiography, 2 runs are important. When you're doing a triple rule out or a double rule out, aortic gating with ECG may be very, very useful in these scenarios. Thank you very much for patiently listening. I look forward to answering your questions.